Good evening and a warm welcome to one and all present here for today's webinar on World Health Day 2026. We at Nurseslab are delighted to present to you our speakers for this evening's webinar, Mrs. Babita Sujit, Dr. Puvaneshwari, and Mrs. Geeta Ramesh. Our first speaker for this evening is Dr. Babita Sujit, clinical nursing educator, Dubai, UAE. Ma'am is currently working at Al Qasimi Hospital, EHS, as a nursing educator, a student, and internship clinical academic coordinator. Ma'am is also a part of the EHS research ethical team and has served as a lecturer, developing and regularly updating nursing curricula aligned with national and academic standards and clinical needs. Ma'am has completed her PhD in nursing at Sri Venkateswara University, India, a professional diploma in obstetrics and gynecology from Royal College of Surgeons, Ireland, Masters of Science in Nursing from Government Medical College, Kerala, India, and has also completed certification courses in instructional methods in health professions educations from University of Michigan and essentials in clinical simulation from the George Washington University. Ma'am has various research articles as well as literature that has been published in well-known journals. And she is also the recipient of various awards like the JCIA and the CCPC Appreciation and Best Employee Award. We welcome you, ma'am, and over to you.
Thank you, dear. Thank you for the warm welcome. Thank you for the nice words. And good afternoon, everybody. And good afternoon to the participants. In connection with the WHO 2026 theme, I got the presentation topic as One Health Blueprint, Why Nurses Must Lead, integrating the human, animal, and environmental health. So from the name itself, we know that this is a call for the nurses. That is, the nurses has a voice in the world, okay, and especially integrating the health of the human beings, connecting to the animals and environment. As an introduction, One Health is an integrative effort of multidisciplines working locally, nationally, globally, and to attain optimal health for people, animals, and the environment. The One Health triad says humans, animals, and the environment are dependent each other. The health of each of the element affects each other also. So in short, we can say, as the diagram says, human health is from environment and the same time from the animals. So if the animals are healthier and the environment is in a healthy stage, we can say our environment, our health also in a safe side. So, as an importance, we can say addressing emerging infectious diseases, antimicrobial resistance, environmental challenges, chronic disease, and health inequities. So, nurses, in a nursing perspective, nurses have the broad set of understanding of the individual and community health needs, positioning them to bridge care delivery and public health. We are a trusted advisors in the communities, workplace, and even the schools. And we are the first point of contact, enabling rapid identification and response to the public health threats. Now, in 2019, you know that once the COVID pandemic was there. So, what was the role of a nurse? So, as Florence Nightingale says, this actually it was an era of nursing. So, it was the voice of the nurse. Everywhere, nurses is in a huge demand. So, we know that nurses has a huge role, demand in this community. As a leaders in One Health, nurses lead transformation by shaping the policies. We are policy makers, driving interventions and educating the communities. Advocating of preventive care and health equity, leading the interprofessional team in various sectors. As an impact in One Health, we are involved in the global pandemics, which are shaping the infection prevention and control policies, community initiatives like health education, vaccination drives, hygiene promotion, also major role in the policy development. Nurses advising on the health legislation, resources allocation, and environmental health measures. Well, as a core competency of a nurse leader, we have strategic vision. We develop the strategic visions, understanding the complex systemic health challenges, interprofessional collaboration, coordinating across human, animals, and the environmental health disciplines, advocacy and policy influence, and health education and literacy, which empowers the communities with knowledge to prevent and manage the risk. In order to transform the healthcare through the nursing leadership, we nurses facilitate integrated, people centered care and support for vulnerable populations addressing social determinants of the health and drive innovation in community based care, telehealth, and environmental health monitoring. For the WHO theme for 2026, Together for Health Stand with Science, which focus trust in science to prevent the emerging diseases. WHO One Health Initiative vision sees a world able to prevent, predict, detect, and respond to the health threats, as well as to empower different sectors to adopt a One Health approach, bringing the health of the people, animals, and environment all into focus. WHO established this One Health Initiative or OHI team in July 2021. The main focus is OHI bridges and accelerates vital efforts needed from multiple sectors and global entities to achieve the SDGs, that is the Sustainable Development Goals, by bringing a holistic approach. Environmental health, in short, we can say it is a public health focused on assessing, controlling, and preventing the environmental factors which affects the human health. As an example, we can see the interaction between humans and their environment, which includes air, water, and soil quality, waste management, climate change, poor environmental conditions, which all increase the risk of diseases. Emerging infectious diseases are diseases that are either newly appearing in a population like COVID-19 pandemic when it first emerged or rapidly increasing in the number or spreading to new areas. For example, outbreaks of Ebola virus disease or Zika virus infection, bird flus. This disease often arise due to multiple factors like climate change, increased global traveling and trading, human contact with the wildlife, and urbanization and environmental changes. One Health approach is a concept which recognizes human health, animal health, and environmental health are closely connected. Instead of treating human disease in isolation, this promotes the collaboration between doctors and public health experts, veterinarians for the animal health, environmental scientists. Many of the emerging diseases spread between, you know that it is between humans and animals. So, by monitoring the animal health, the scientists can detect and prevent the outbreaks of most of the infectious diseases earlier. What is the interconnection between human, animals, and the environment? Historically, there has been insufficient understanding. And is there any linkage between the health between human, animals, and the environment? But with over 15 million human deaths and US of 4 trillion in economic losses due to various infectious diseases and pandemics, which cause an immense loss from the food and water safety risk. Threats such as climate change, environmental degradation, zoonotic diseases, antimicrobial resistance, all these ongoing human activities impacting the animals, plants, and our environmental balance and well being. First, on climate change as a central driver. Human actions like burning fossil fuels, deforestation, industrial, agricultural increase the greenhouse gases, leading to climate change. It leads to rising temperature, which expands the habitats for the disease-carrying organisms. Also, the extreme weather conditions like floods and droughts disrupt the ecosystem and sanitation. Wildlife migration changes, which increase the chance of new contact or near contact between the species. This all increase the spread of zoonotic diseases like bird flus, Ebola viruses, monkeypox, severe acute respiratory distress syndrome, all these things. Environmental degradation, deforestation, pollution, habitat loss, these all activities like logging, mining, and urban expansion destroy the natural habitats, which leads to wildlife forced to closer to the human settlements because of the deforestation. Loss of biodiversity weakens the natural disease regulation process. Polluted water and soil affects the plant, animal, and the human health. For example, deforestation in a tropical region, which is linked to the outbreaks of Ebola virus disease, because humans comes to closer to the contact with the infected wildlife. Another is zoonotic diseases, that is, the transmission from diseases from an animal to human. 75% of the infectious diseases come coming from animals. Wildlife trade and wet markets increase the exposure. Intensive livestock farming creates disease hotspots. Habitat destruction increases the human animal interaction, like SARS disease linked to the wildlife markets, Ebola virus linked to the wildlife reservoirs. Antimicrobial resistance. As you all know, AMR happens when bacteria evolve to resist the antibiotics. Human cause like overuse of antibiotics or over the counter antibiotics in healthcare, heavy use of antibiotics in livestock farming, and improper disposal of the contaminated soil and water, which results in resistant bacteria, which spread through the food chains in among the animals, its water systems, and direct contact between the humans and animals. This makes infections harder to treat and also increase the benefit of the antibiotics, reduce the benefit of antibiotics, and increase the health risk. Food safety hazards, which connects human beings, animals, and the environment very closely. And like contaminated water used in agriculture, pesticides, overusage of pesticides and chemical residues, pathogens from the animals entering the food chain, poor hygienes in the food processing time. This whole and also climate changes, which indeed reach to a stage that there is an increased bacterial growth in the warmer temperatures, causing the crop contaminations. How everything is interconnected. These issues doesn't occur separately. They all are connected each other. Climate change, which indeed causing a habitat disruption for the animals and even human beings, which leads to a zoonotic disease spillover. Poor sanitation, of course, there is a reason of disease spreading. Intensive farming, overusage of antibiotics, which leads to antimicrobial resistance. Environmental pollution, contaminated food and water, which leads to the human illness. Biodiversity loss, which leads to fewer natural disease controls and more outbreaks. Like deforestation, which leads to wildlife displacement, increasing the human contact with animals, which leads to zoonotic diseases, which in turn increase the antibiotic uses. This will be causing an antimicrobial resistance, and there will be a harder to control these outbreaks and treat the diseases. One health insight, the core idea is human health depends on healthy animals and a healthy environment. When we human beings destroy the ecosystems or overexploit the animals, pollute our air, water, and soil, we unintentionally create conditions for new diseases, drug resistant infections, and unsafe food systems. What is the role of nurse here? Nurses play a critical frontline role in addressing these climate change impacts and emerging diseases, zoonotic risk, and AMR, and the food safety. What is our role in disease prevention and health promotion? We can educate the patients and communities about the hygiene, sanitation, and the safe behaviors, promote the vaccination to prevent infectious diseases, raise awareness about the zoonotic diseases and the spread or the transmission of these diseases, proper hand washing techniques, and the safe food handling techniques. For the early detection and surveillance, identify the early symptoms of infectious diseases, report initial outbreaks to public health authorities, and participate in the disease surveillance systems. That means early detection always helps prevent large scale outbreaks. Combating the antimicrobial resistance. Ensure antibiotics are used only when prescribed. Educate patients to complete full antibiotic courses and prevent infection, which reduce the need for antibiotics. Environmental health advocacy. For that, educate the communities on clean water usage, waste disposal, and pollution prevention. So, One Health collaboration is work with veterinarians, environmental experts, and public health teams. Understand the link between animal health and human disease. Advocate for environmentally sustainable healthcare practices. What are the preventive aspects? What we should follow? First one is personal hygiene and sanitation, regular hand washing, drinking water, infection prevention, proper vaccination, use of PPEs whenever needed, avoid contact with the sick animals, environmental protection, reduce the pollution and waste. Also, the waste management, proper waste management system, support sustainable practices, also in order to protect the natural habitats. Prevent zoonotic diseases so that we have to avoid unsafe wildlife contact, ensure proper cooking of the animal products, and maintain hygiene when handling the animals. Responsible antibiotic use. Do not self medicate and follow the prescriptions correctly. Also, avoid overusing of antibiotics in humans as well as in animals. For the food safety, wash the vegetables and fruits properly, cook thoroughly, and store in a safe temperature. Climate related health awareness, prepare for the heat waves, floods, and other climate impacts. Also, prevent waterborne and vector-borne disease. To conclude, by integrating this environmental awareness, scientific evidence, and nursing assessment, we can prevent zoonotic diseases and improve environmental health and build a healthier future together. Nurses are essential in assessment, prevention, and education. We have a pivotal role for the One Health model. Their leadership ensures collaborative, sustainable, and equitable health solutions. Empowering nurses strengthen the resilience of the healthcare system and communities. Working together with science ensures better global health outcomes. And thank you so much.
Thank you, ma'am, for the detailed and informative session. Our second speaker for this evening is Dr. Bhuvaneshwari Kanagaraj, Assistant Professor, University of Bisha, Saudi Arabia. With over 25 plus years of experience in the field of nursing education and clinical practice, ma'am holds a key academic and administrative roles, including lab coordinator, training head, and program coordinator at University of Bisha. Ma'am is a gold medalist and holds a PhD from distinction from various reputed universities and is a recipient of various prestigious awards. Ma'am is also a resource person in over 35 plus national and international conferences and webinars and is an award winning presenter and evaluator. Ma'am has over 23 plus publications in over well known journals such as Scopus and Web of Science journals. We welcome you, ma'am. Over to you.
Thank you, Ms. Tanya. Good evening, everyone. So I welcome you all and thank the organizers for giving me this opportunity to present a topic related to this webinar. The topic which is given for me is artificial intelligence as an intelligence layer, science at bedside. So it is completely a different title, what the first speaker spoke. So it is two different aspects. So that is something related to the community health, and this topic is very closely related to the bedside. So the objectives of this session, I'll be covering why artificial intelligence is needed in healthcare and how exactly it works, and what are the complex data they will be using in hospital to utilize this artificial intelligence, and what are the core components and application of AI, and what are the challenges and limitations we face, especially in India, and few case studies as well as a few evidences of AI application in India. As we all know, the theme of World Health Day 2026 is Together for Health, Stand with Science. So it has a different aspects, like as the previous speaker spoke something about community. Since the title was given with the AI, I looked into that aspect also. So it focuses on evidence based. So that word of evidence based, always it comes with research and collaborative solutions to global challenges, making the AI a central topic for modern scientific data driven advancement. So definitely this particular title also will go very like a close relation with the World Health Day theme. So thank you for the organizers for choosing this particular topic, and it is like because everywhere we speak about artificial intelligence, but we don't know exactly how it works and what is the application of AI in our country. So in that aspect, so really it is a very good title. So when it is coming to an artificial intelligence, how it works and why it is needed, why in our healthcare it is needed, there are various reasons. I have picked 8 reasons. The first one is shortage of healthcare professionals. As we all know, like with a lot of statistical evidences, we all are aware that shortage of healthcare professionals are there. Even during COVID-19, we faced a lot of issues, but still it is not resolved. They say approximately 5.1 million healthcare professionals are needed in 2030. But we are not having that much the development of productivity of the healthcare professionals. So shortage is very high. And countries like India, according to WHO, they say it is 1:1,000 population. There should be a doctor. But in India, the ratio is different. The similar way for nurses also. And the shortage is very high. And nurse doctor ratio is 1:3. But in India, we have at present 1:1.9. So this particular ratio definitely will increase as the workload of the nurses, workload of the healthcare professionals. So here the term healthcare professionals, it not only includes only nurses and doctors, it includes everyone like allied health people and radiology technician, Ayush, homeopathy, all different healthcare professionals. So on the whole, we have a lot of shortage. So the workload for the healthcare team is very high. And the second one, rural-urban healthcare disparities. Approximately 75 to 80 percentage of people live in a rural area, but the healthcare facility is very good in urban compared with the rural area. So there is primary health centers, community health centers in rural area, but the infrastructure is not well developed. Not only infrastructure, even the manpower too, whether doctors or nurses are not much willing to go and work in the rural area compared to an urban area. Everyone try to shift it to an urban area. So again, that treatment of or the care what the people receive is it is little difficult. And because of that, the maternal death rate, all those things are increasing, or early diagnosis is delaying. So that is a one more disparity. So where maybe AI can help us, and if they already started in India in few things, maybe in the future slides we will see. Third one is medication errors and patient safety. Whenever we talk about medication error, we always say 50 percentage of medication errors can be preventable, but still we have errors. Approximately 1 by 10 patients are like having one or the other issues related with the medication error. It can be a prescription, or it can be administration, or it is a dispensing of medicine. Maybe one or the other way the people are in threat. So medication error can be prevented by some systems which we will be seeing in detail in AI. So that will help the patient safety. So it's a very, very important thing in medication error prevention. AI has a good role. Need for standardization and quality care. So this also another important issue when we talk about quality. We don't have much like very standardization of protocols. Even just now we saw rural and urban. When it is coming to rural and urban, also the care is different, and the experience of the people are different. Some areas are unexperienced people are also treating, and some areas specialists or experienced doctors are also treating. So where there will be a lack of standardization with the care what the patients are receiving. So AI has a different protocol. So whether it is an experienced doctor or an experienced nurse or an unexperienced nurse, but the standardization to be followed. So with that, the quality care can be provided. Next one, high patient load and disease burden. This is another important issue in India. As we told, the shortage of healthcare workers, so automatically the patient load is increasing. When the patient load is increasing, the doctors and nurses are making error, and disease burden, especially with both communicable and non-communicable diseases, are very high. And in 2020, we faced COVID-19, which is a communicable, and approximately 65 percentage of the death are happening with the non-communicable diseases. So the diseases like cardiac illness or cancer or some of the respiratory illnesses, these are all nowadays it is increasing. So this disease burden also like even diabetes mellitus, which is leading to a chronic disease. So the disease management can be done with the help of AI. So the number of people coming to the hospital can be reduced by a direct contact. So through different apps, we can contact a patient, doctors or a nurses through like indirect way, like maybe a telemedicine or a telenursing. So that will be helpful. So that is a one way. Next one, need for early diagnosis and preventive care. Early diagnosis, that is very, very important, especially the diseases like cancer or tuberculosis. So the early identification, sometimes when it gets missed and patient come to the hospital at the later stages like grade 3 or grade 4, it is difficult to treat the individual. So that is also another important thing. And whenever like now if we are going to a tertiary care hospital, we can see if you go to the hospital in the morning, the outpatient department, the crowd is very high. So people are little hesitant to come sometimes to the hospital when there is a mild illness. But that mild illness, if you would have diagnosed it in the early stage, even if it is in a rural area, for example, an X-ray, they are doing an X-ray for suspecting a tuberculosis. Maybe a human eye is missing the early diagnosis. So, but an AI can identify that. So, when it alarms us or when it gives a reminder to us, so the preventive care or the treatment will be started in quickly. So, that is also one more reason. Then, efficient health data management. So, health data management compared to other countries, the health data management in our country is still growing, improving, and the data is very fragmented. Like maybe the person who is going to the hospital one time, when he goes to the second time, unless he takes his case sheet and go, the data will not be compiled like electronic health record. But there are hospitals, they started maintaining this electronic health record. Or so this artificial intelligence definitely help in managing or clubbing all the data. So definitely a patient will be getting a lot of benefit in, especially in the chronic disease management. The last one, constraints in healthcare. So even when we are starting initially, artificial intelligence, definitely it is it takes a lot of money. But when it is utilized by many people, definitely it will be reducing the cost in the healthcare. So that is one reason, that is a reason which we are just trying to focus, cost constraints, because the health team, healthcare nowadays is very costly, and the patient should come directly to the hospital, like that. So many things are there. So that will be leading to a increased cost constraints, and the duration of admission in the hospital, for maybe 5 to 7 days for some illnesses. But if the surgery is done with the robotic surgery, the length of stay will be less. But at the same time, the cost is still high. But wide world, widely, when they started using these type of treatment, then the cost will be coming down. So in that way also, AI will be helpful. So this is the main focus. Nowadays, every hospitals are trying to start with an AI in their health system, one or the other way. So as we say, AI is an intelligence layer. How it exactly works? So it is a system which is designed to simulate the human intelligence in performing complex clinical tasks. So it is a touch between a human intelligence as well as the machine intelligence. So it enables the machines to learn from data. The word data is very important because it tries to get all the information. Unless the data is there, artificial intelligence cannot work effectively. And with the data, it recognizes the patterns and it makes its own decision. So AI supports the clinicians by transforming the large volume of health data into a very meaningful, actionable knowledge so the doctors can take a final decision. And it also enables a very predictive, personalized, and preventive care. So in that way, really it works as an intelligence layer between the healthcare workers, whether it is a doctors or a nurses or other allied healthcare people. And what exactly it does, as I told, it needs a data. Electronic health record, that is EHR. Nowadays, many hospitals started adopting to this. So from that electronic health record, it takes the data. And whatever the laboratory results which is already deposited in the data, like complete blood count or whatever the blood investigations we are doing, that it is going to analyze along with the EHR. Medical imaging, it can be a CT scan or it is an X-ray or it is an MRI or whatever it is. So that is also going to help here to give data. So that it is trying to take. And wearable device data. There are so many wearable devices nowadays. Even a smart watch will be helpful to calculate the heartbeat or blood pressure, and it gives a reminder. And there are different apps what we are using biosensors, like that, so many wearable devices. But all these things has to be interlinked. Then only it can collect all the data and tries to identify the patterns, or the it can make a prediction. So even it identifies the hidden patterns and correlations, why it is happening, how it is happening, like that. And even beyond the human capacity, it is able to tell the doctors, and supports a real-time analysis for faster clinical response. Quickly it will alarm us. Quickly it is going to tell within 24 hours what is going to happen for this particular client. Like that type of analysis also it is doing, and it enhances the accuracy and consistency in the decision making. So that is the way the artificial intelligence it is working in the healthcare system. So what are the core components of AI? There are so many technical terminologies are there, but something which is very related to our field, that is a healthcare field. I have just taken four important components. One is called machine learning, deep learning, and a few more like natural language processing. We'll see in the next slide. What is machine learning? So machine learning is an algorithm that learns from the historical data. Historical data from where we get it from the patient. So from the patient's data, it tries to make prediction. So like even a past history, a patient, like whenever we go to the hospital, usually, the data collector in a tertiary care hospital, they will sit and ask the data. Father has a illness. Okay, diabetes, yes or no? If yes, how many years? Mother, yes or no? If yes, how many years? Father is alive, mother is alive. If we say dead, okay, what is the age? Like that, so many data they are collecting nowadays. So these data, once it is collected together, definitely those are applying an AI. It will take the data and try to give a prediction. So it will give a prediction like which type of diseases this particular individual is prone for, and what are the risks they have in further with their history. So that is the way the machine learning is working. And the second one is deep learning. So this deep learning, it is having an advanced neural network. It is trying to get all the information and medical images, as we told, like X-ray, CT scan, MRI, those informations, and the ECG value, ECG signals, and radiology, that is MRI, all the information it is trying to get it, and it understand deeply, and it is giving a output. So that is something called as a deep learning. Another one important thing is natural language processing. This even some of the hospitals are adapted in India also in some areas. So it enables the computers to understand the process, like the clinical data, or sometimes the doctors will be talking and there it will be recording the information. No need for a manual writing. So it understands the clinical notes and it makes its discharge summaries and the patient records. And once the doctor can go through and they can just give a signature. So there is no need for a separate manpower to do all these process. So natural language processing is helpful in that aspect. Next one is predictive analytics. This is very, very important. This predictive analytics and machine learning, deep learning all work hand in hand. So it uses a statistical models to forecast the outcomes. Like as I told, the historical data you get it. So with that, the risk prediction they are identifying. Similar way, when a patient gets admitted in the hospital with the patient's clinical parameters, it identifies, it is going to tell us like this patient is going to deteriorate, or like even a sepsis in countries like US, when they are using this predictive analytics for identification of sepsis with the various parameters. So the patient deterioration and readmission risk, how many, whether this particular patient will come back to the hospital again within a few days because of the problems what at present it is there. So the risk, how much it is, what are the complications. So when we alert that all the things to the patient, so it is like we can protect them and we can prevent them from the further issues. So like that, so many applications it has with the different core components. So now we will see exactly how it works out in our hospital setup with the different aspects. So I try to take some 11 important aspects. One is early detection of adverse events, reducing medication errors. As I told, why we need AI, enhanced diagnostic accuracy, predictive analytics for risk assessment, bedside documentation, workflow automation, clinical decision support system, and another important one, safety and robotics. Nowadays, many hospitals started using patient engagement and monitoring, fraud and risk detection, and learning system. So these are the areas today we will just see with a little explanation. The first one, early detection and adverse events. Okay, as I told, machine learning, it plays a very, very important role in identifying or by having a different diagnostic tests. So with that, it enables for the early detection of the problem, and it is also supporting a clinical decision making. As I told, ML or NLP, or it is a predictive analysis, everything, or deep learning, everything will go hand in hand. So with that, like we can easily identify the problems, and it analyzes the physician notes, whatever the data they are writing it. With that, it predicts the risk of death, even the length of stay and readmission, which I told. So there are some down, I have mentioned different softwares, Prognosis, NYU, Langan Health, Akira AI. These are all the some of the softwares which uses which we are using. Even Akira AI software which is used in India also for early detection of adverse events in some hospitals. There are like various tertiary care hospitals like Manipal, Apollo, Narayana Hridayalaya. Like that, there are so many hospitals, AIMS. They are using one or the other way a different AI in their healthcare system. Next one, reducing medication error. When it comes to a medication error, we have different aspects. It can starting with the prescription or dispensing or administration, all those things. So even it cross-check the validation. When a doctor is writing a medicine, even it cross-checks. So that is the prescription validation. As a side, I have given like a different what is it, software like Epic or FDP. These are all very important softwares which we are, even in India, we are using it. So cross checks for interactions. When the particular data is already existing, which is tied with the electronic health record, it is trying to identify, okay, this particular patient, this problem is there. So when a doctor is prescribing a medicine, it will be trying to check whether it has any interaction with any other medicines what the patient is taking, or with the illness what the patient is having, and any allergic, any contraindications will develop, and even the dose it will try to, based on the weight and other. But for that we need a data. So all those things. So it is trying to validate the prescription. So even the doctors can make errors. Human beings can make an errors. So it is trying to cross check so the patients are in a safe side. Automated alerts, real-time warnings for a risky orders. So for that, this particular FDP Med Knowledge app they are using. And personalized dosing, adjust the doses by age and organ function. Maybe the kidney is not like normally when we see a patient like having a kidney failure or something, we will see like an alert, they will write outside no NSAID. Nowadays also they are using like that. So like that, so it is alerting another person, don't administer any NSAID even though the patient is having a pain. So like that, it is able to immediately tell, and it is adjust the dose, and it alarms the doctor. Next one is safe dispensing and administration. So safe dispensing and administration. So AA enabled dispensing cabinets are there. So once we put that like the details, automatically it will cross check everything and the medicines will be dispensed. So this is also one of the important thing which reduces the medication error. And enhanced diagnostic accuracy and medical imaging. So this is even in India we started using it. As I told, analyzing the imaging like X-ray, CT scan, MRI, ultrasound, even the lab reports, all those things, quickly it will be able to understand and interpret it. With that, early identification and risk stratification can be done by the physicians, and even diagnostic errors can be avoided. For example, if it is an ECG, normally when we get an ECG, there will be a report, a small report. Is it a sinus rhythm or something like that? But AI is able to identify even a very minor error, a minor problem for the client, which is going to maybe lead to a critical issue. It is even the doctors miss sometimes. So this is able to identify. So that is something about enhanced diagnostic accuracy and medical imaging. And with that, we identify major diseases like cancer, even fracture, sepsis, cardiac events. So these are all the different softwares like DeepMind, AlDoc. This is helpful and reducing a misdiagnosis and delays in the treatment. So always it works like a second opinion for the doctors to improve a clear decisions. So even the DeepMind will tell about breast cancer, and AI Doc, it flags about the issues like stroke or any minor bleeding. Alivcor, it is identifying an arrhythmia. So these are all the different existing softwares related to the diagnostic accuracy. Predictive analytics for risk assessment. As we told, risk like even a fall, risk of fall, all those things can be identified with this, or a sepsis, as I told before. So predictive analytics, it uses a standard algorithm, and it is trying to get the historical as well as real-time patient data. So with that, it will link every information, and it is categorizing whether the patient is with low, moderate, or high risk. It has a lot of protocols. I'm not mention all the protocols here. So just told generally, it is something category risk scores. It has different things like bed sores or fall risk, which we are manually already doing, but little more advanced, so we can prevent the issues, the chronic illness identification, everything. And in that, the different models like Epic Sepsis model, it is a software, and Quantus AI, Microsoft Azure machine learning. So everything has its own protocol. So with that, when we have all the data, this particular patient is risky for this. Like that, we get a alarm. So it alert the nurses even within 24 hours. This patient is at risk. So we are ready to prevent any major complications for the client. Bedside documentation. So this is an interesting thing. Bedside documentation. So what we do nowadays, like that, when we are using an artificial intelligence technologies, like in mobile, especially like Spark or Nuance Dragon Medical One. So the doctors, when they are giving an information about the patient, there is no need for the nurses to take a notes or a physician assistant to take a notes. This particular app will record all the information. It recognizes the doctor's voice, and it gives all the information. So no need to go typically, like normally what we do, like typing or writing, that is not needed. So quickly it gets all the information, but again, it should be cross-checked by the physician. So whether the information is correct or not. So this bedside documentation, it is really nowadays we are doing. So I had an extra 2 slides related to this. There are different aspects we use, like NLP, as we told, like it recognizes the human speech. It recognizes the medical language. Even it recognizes the text, what we are writing. All those things, it will be able to capture it. And real-time auto-filling. When we have an EHR, all the data, whatever data the doctor is asking, all the information will go and sit in its place. So we can quickly get a data from the EHR. And auto summarization of patient encounters, it makes it summary, it makes a discharge note, and alert generation. Suppose we are missing some information in data collection, it will alarm us, no, it's missing, like that. So that way, advanced bedside documentation have come. And in even in Narayana Hridayalaya Hospital in Bangalore, few places, the bedside documentation already they have implemented. But everything is like a trial basis, they are doing it, and when it works out well, they'll implement it. So this is an estimated, like how we have started using in India, with the traditional as well as the bedside documentation of AI. In India, we started using approximately 10 to 15 percentage. So mainly they are like Dozy, HelpPlix. So these are all the different AIs they are using for doctors. But when it comes with the nurses notes writing, it is very minimal, less than 10 percentage. So the documentation, still we are doing it by a very manual way. So that is the thing. And here I have given some evidences also where they are using. And in Saudi, where I am working, approximately they are having like 30 to 45 percentage. They started using, and they have a vision of 2030. With that, they are increasing the usage of artificial intelligence by doctors. Again, nurses, the ratio is little less, like 15 to 25 percentage. And UK, it is 20 to 25 percentage. And again, nurses are little less stage, like less than 10 percentage. But US is using more. Approximately 66 percentage of physicians, they are started using an AI tools, and 21%, that's a big number. Bedside documentation, approximately 21 percentage they are using the AI. And nurses are also using approximately 35 to 40 percentage. So hope this particular aspect of AI will come soon, widespread in India also. Next one is workflow automation and decision support. This is also very, very important. So it streamlines the clinical tasks and give a clear information, and it is avoiding the errors. So by different ways, like it gives an automated reminders, and it has its own protocols and checklist. And even we are using CLABSI, all those things, infection control protocol. Similar way, it also has it is updated with the infection control bundle, so it will alarm us. And very important thing, clinical decision support system. So the clinical decision support system is very, very helpful for the doctors whenever they are prescribing a medicines. When they are having a doubt, there is a which type of diagnostic test to be ordered for the patient. Even in that time, it will give a clue, and it gives a very clear idea for them to further proceed. So that is the workflow automation and decision support. So we use AI chatbots. So it is different apps like Ada Health and BioHealth. And so it is helpful to maybe for a communication or information transmission from doctors to the physicians or nurses or specialists like that. But at the same time, it gives a lot of reminders. So symptom check will be very helpful. And virtual nursing assistants provide a medication reminders. So this is like Sensely. This is one of the app where it gives a discharge instructions and monitoring recovery, all those things. These type of the workflow automation will be helpful. Smart CDSS, example is Epic and Cerner. So these are all the different way of workflow automation is helpful, and we started using also. Even there is a systematic review which is published in BMJ in 2022. They say CDSS reduced medication errors up to 50%. That's a very good percentage, because we say approximately 1 by 10 people, out of 10 people, one person is having a medication error one or the other way. Either the dose, or it is the wrong medicine, or it is the wrong administration. So this is very helpful. It prevents the error. And clinical decision support system, AI powered CDSS, along with the electronic health records. Definitely, it is helpful with all the core components like machine learning, big data analytics. Definitely, quickly it analyze the big data, cloud data, and give information within seconds. So that is something about the clinical decision support. So it collects the data. It collects the data from the records, vitals, imaging, lab reports, everything. From that, everything it gets, and it clean all the data, integrate and analyze it, and immediately it is producing a result like pattern recognition, how it is, how the pattern is going to be, whether the patient is going to be deteriorated or the patient is going to improve, like that. And clinical decision support, it gives a alarm, it gives a treatment recommendations. As I told, it will tell this or this. If you opt this, this is that way of no management, we have to proceed like that. So it gives a very clear information. It gives a clue, so we can prevent errors. And personalized care planning. So these are all the way this clinical decision support system is working. This clinical decision support system, doctors are using, not nurses, but in countries like US, in many places, many areas, they are utilizing this CDSS. Next one, safety and robotics. We already know about robotics nowadays. Many hospitals are having a robotic surgeries, but this robotics are again included with the artificial intelligence. So it is helpful in pre-operative planning. It looks into the image and it will tell how precisely we have to go for a surgery by looking at the size, all those details. And so very, very helpful in the pre-operative planning and intraoperative support. So the robotics systems enhance the precision. Definitely, robotic surgery reduces the length of hospital stay and reduces the blood loss. So many benefits we have for robotic surgeries like or a delivery, or many clinical conditions we are using. So this robotic surgeries are assisted with an AI. Definitely, it is added benefit. So real-time AI tracks the vitals, and it prevents the complications with the robots. And post-operative care also, it is preventing like higher risks of infection is reduced, and bleeding will be reduced, and because it is alerting us. So there are few examples are there, Versias, Globus Medical. These are all the different AI robots which we are using nowadays. And this is about the computer vision robots. So safety robots in terms of surgery, similar way, vision robots. So this is helpful for identifying the fall detection. This is the first one picture Like example, even they are using it in MRI rooms or diagnostic rooms. They keep this particular camera, so it will be watching a patient if there is any abnormal movement or even related to this COVID-19, the observation from far. Where there is a need of communicable prevention, isolation precautions to be taken. So these type of robots were used. So it identify even a fall prevention. It will alarm us so quickly we can take action even there is no manpower is in that particular place. And ICU monitoring and medication dispensing robots. So what this medication dispensing robots will do, it will take the medicine and go and give it to the patient, but it will cross check all the things like no barcodes, fingerprint verification, everything. With that, it will take the medicine and it will be even administering the medication to the patient. And assistive care robots, so even the carrying the medicines, some routine work where there is a no need for a human being, that can be used. So this is also widely used in other countries, not in India, but these all are different AI models with the robotics. And patient engagement and monitoring with the AI. As I already told, it is little repetition, monitoring. Completely, it is watching a patient, having a wearable devices when you have, it is trying to look into that, like completely it is monitoring how was the BP yesterday, today, everything, and glucose monitoring. So with all those things, the patient will be having a clear watch, and the chronic disease management can be done for the client. And personalized reminders, when you have that app, it will give a reminder to you, this is the time for you to take a medicine, like that. So the medication adherence is also very good with the chronic disease management. And remote monitoring, when a patient is unable to come to the hospital, yes, they can be monitored from far also. So for that, Bioformis, so that is an app which they are using for a patient engagement and monitoring. Fraud and risk deduction in health system. So this is something even an administration aspect we can use. So AI detects like sometimes no, they will apply for a double claim, or maybe some procedure is done but it is not billed, or some procedure is double billed. All those things it can easily identify. So it definitely helps the patient in terms of a cost. So that is about fraud deduction. Risk deduction in clinical practice, like identifies unsafe practices, and even though it will be identifying which are some unnecessary tests. Sometimes when the doctors are writing a diagnostic test which may not be needed, but they are writing it again, maybe it is done 2 days before, again they are repeating it, so it will tell it's not needed, like that. So even in that way, it will be very helpful for the public. And policy compliance monitoring, so it ensures that the hospitals and clinics follow whether they are following our safety protocols and their billing regulations. Like we go for a NABH accreditation, all those things. People will come and check us and whether we are doing. Even in that, AA plays a vital role. So whether they are violating all those things. So when you work with that system, even the your clinical auditing will be done in a very good manner. So these compliances also it is doing. The last one is learning health system. So learning health system, like as we told, collect data. Collection of data is very, very important. Unless we don't have much data, AI cannot work. So the data aggregation. So electronic health record to be connected with your digital monitoring. It has to be connected with the patient information, all the other information. So when it is accredited together, definitely AI will be helpful. It is helpful for identifying the pattern analysis or trend analysis. So in that way also AI is helpful. So that data collection is important. So we have seen quite a few applications, but there are a lot of challenges and we are just growing. So challenges are high. What are they? First one, data privacy and security. Anything is related with computer or an AI or software, definitely data privacy. And again, it is a patient data. It is a lot of informations are there. So the institutions should be very careful, and there is a chance for data breaches or cyber attacks. And who is responsible for that? Whether the institution or the people, those who are giving us the software. So there are so many administrative issues are there. So that is something about the challenges related to the privacy. So how it has to be stored, what are the ethical data sharing which has to be maintained, all those things. The second one, integration with the existing clinical workflow. As I told, electronic health record should be there. Then only it can be connected with one or the other, the tie-up. So the information will be adequate for the AI also to understand about the patient issue. That is one thing. And resistance to change. We are resistive. Like we are not willing to take this. We are so scared when AI comes, whether we are replaced. So resistant to change by the human being and increased workload. When we are initially implementing, manual recording was comfortable for us. And when they are initially implementing, it is very difficult. No, because of all these things, we are feeling so much workload. Like that, that also can happen with the initial implementation. So people will not be adapting. So with the pilot study, it gets dropped out. And poor integration can lead to definitely workflow disruption. And instead of improvement, there will be a deterioration in the hospital workflow. So that is something very important. So we need a training, we need an adaptation and user-friendly design. That's why hospitals, when they're using a one software, they are not comfortable, then they stop that and go to another one. Like that, that AI applications are going. Next one, dependence on high quality and representative data. This is very important. As I told, the data should be correct. The data should be complete. If we are giving an inaccurate data or incomplete data, then AI will be giving a result according to that. So we have to be very, very careful in giving information. And lack of standardized data format. When we don't have a clear-cut format and we give a half information, so AI will not work in that way. So that is very important. So standardization protocols to be made before we started implementing the AI. And poor quality can definitely lead to a very big danger. Incorrect prediction, wrong analysis, wrong result, and the treatment will be going wrong or patients will be suffering. So that is something very, very important. Then ethical consideration. As we know, wherever we are using data, definitely ethics is important. So many AI models, we don't know how it works out. So they call it, as doctors are calling, like a black boxes. So they don't understand how exactly it works out. So that is the transparency is not that. That is one thing. And bias, and AI can inherent biases, like it needs a like training data. So it can lead to an unequal treatment outcomes across the population. And accountability. This is what I told. Who is accountable? If the data is leaked, who is accountable? Or the informations are like it is predicting wrongly, who is accountable? Whether the person who had given a data is accountable, or the AI is accountable, or the software is accountable. So like that, so many concerns are there. So we need to create a lot of what is that, guidelines for this. So this is one of the example, like few case studies I have mentioned. So this is Ognito Voice AI, which was used in Narayana Health. So this is a cloud-based voice-to-text tool. So the doctors will be just telling, and automatically the data will be recorded. So they say like 35 to 40% of reduction in the average time. So the workload is reduced for the person who's working. So that was one important benefit out of it. Then there is one more called Dozy. This Dozy they are using, they used in AIMS New Delhi, especially during a COVID-19, the high dependency units, as I told, where there is a less contact is needed, like PNAS patient contact we need to reduce because of this communicable diseases. So this was very helpful. It was trying to get all the information like heart rate, respiratory rate, SpO2 without having a contact with the patient. We are getting the data. And auto-generated shift summaries also, it helps like alarming about the deterioration of the client like that. So it was very, very beneficial. It is one of the evidence which we have used it. Then HealthClick's EMR, electronic medical record with the AI. Nowadays, small hospitals also, mid-sized private hospitals across India, they are trying to use these type of AI assistant. So it is integrated with the lab report, some medication decision support they get it. And even it is available in different regional languages like Hindi or Malayalam or Kannada, Tamil, like that. According to that, it is available. So what they say, it reducing the consultation time. So quickly they can have all the data. So within a very short period of time, they were able to generate the data. So that is one more benefit. And the last case study, what was this? Curie.ai plus Trigog. So this is many hospitals are using nowadays, even in the cardiac centers of Tamil Nadu and Maharashtra. So the ECG, once it is coming, it is generated with the auto documentation with the precision, not just a rough value. It is giving a very clear information, and it is alarming the people. And even an X-ray report, even in India, as I told, Tamil Nadu, even in TB centers, they are using this. So X-ray report will give a very clear information and then it is connected with the electronic medical records. It is giving an information within 5 to 7 minutes. So quickly we can identify with the ECG, okay, and even it can be happen in the primary health centers. If it is tied up, then the patient can be shifted to a tertiary care hospital quickly without much delay, and the ECG is identifying a patient with even a non-ST segment elevation, because ST elevation all of us are very clear, okay, this is an ST elevation MI, but non-ST elevation we miss it and we may lose the patient. So but this is able to identify that and shift, we can quickly act and we can shift the patient to the other hospital. And so that is all case studies and few more evidence, it is useful in public health, it is useful in diagnostic areas. So this is actually this information I got it from Times of India. They say like 17 major healthcare facilities across the India, almost 150,000 chest x-rays and 1 lakh MRI spine scans are evaluated with an AI, and it identifies the pathology correctly and it alarms the primary health center, so the treatment, the patients are getting shifted. So it is really a very good benefit, especially in the rural areas. And the second one, A in public health, like detection of tuberculosis, cataracts, cancers, even in the government hospitals with the imaging studies, they can do even the EIA integration in NICSHI, that's the program, with the TB monitoring. So the patients are identified with the early tuberculosis. Even though there is no patch, a human being is unable to identify, AI identifies that. And workplace safety, not only for patient and doctors, even for the nurses or the other healthcare workers, that is those are giving a care, even there, for them, there is a safety app they have created in Sri Jayadeva Institute of Cardiac Sciences in Bangalore. Strict actions are harassment cases. Even for a manpower also, there is beneficial, not only in the patient and their treatment, even we people are also, that's one evidence I saw, so I thought I'll put that too. So it is helping for the human being. So when we are trying to compare with the other countries, we are not well grown, we are just growing, and we are mainly using this AI application in diagnostic support, as I told, imaging studies and hospital operations and navigation, patient navigation. For that we are using, but US is using in sepsis reduction, mainly the clinical applications they are using along with the other areas, and UK early warning systems and proactive monitoring, in those areas they are using. Regulatory oversight, we are just emerging, we are just framing it. And as we all know, like FDA is a main thing for US, and MHRA leadership under UK, they are regulating it. And ethical consideration, we are just developing the standards. And US, they have a very clear ethical considerations, mainly on the patient-centered AI use. And UK focus on governance and oversight. And privacy concern, that is a big issue, as we told. Addressing the data privacy issues in India, we started working on. And the US also, ongoing discussions on data security. And UK, they are ensuring safe use of data for AI innovations. And the last one, hospital AI adaptation rate. We don't have much data as such. Like when we are trying to get the information, it is like from a newspaper or sometimes from a journal studies, we are getting this information, or from the hospital database, hospital sites, like that. Not exactly a very clear statistics we are getting about India. So the limited national data, and US very clear, like 70%. Even the previous one study was telling 66 to 70%. They are adapting this AI. And UK also is very less, and it is 8%. So that is a comparison of different countries. But in another 5 to 10 years, we also may be increasing the percentage of utilization of AI. And this is one study which was published in one Q2 journal, a recent study. The people, those are working in the hospital, like what is their mentality about the adoption. So they say the number of sample was 350. Mainly they took the medical students, faculty, as well as nurses. So they say primary AI use areas, they are using like 71% related to diagnostic. That is the highest. As I told, diagnostic areas we are using little more, and treatment protocol development they have like 45 to 4%, and drug development 33.1%. I don't think the number 71 means it's a big number, but out of the 10%, this is the highest area what we are trying to give it. And technical skills, we don't have much technical skills. That was the reply that was given by medical students. nurses and faculty, everyone. But medical students showed little higher proficiency comparing to the nurses and the faculty. An ethical concern, they were approximately 46%. They were saying about data privacy and security, and they were saying about high cost, which is like 23.7%, and over reliance on manual process. Still, we are having that is another thing, like 16.6%, they said. And attitudes, if we are looking into that, medical students have high attitudes towards the AI, but nurses have like only 29.4 percentage. So maybe the reason is they don't have training. So when they were looking into that, they were saying 97 percentage of nurses wanted to learn. They have a higher willingness to learn the artificial intelligence. That was a thing. So if they are trained, definitely their attitude will be changing towards that. And confidence and usage, mixed perceptions were there, like 35 to 35.71 percentage. They say that it improves the outcome. Some men say no, it's not improving the outcome, like that. But anyway, with the long run, with a lot of research evidences, with a lot of applications, only we will really come to know how AI is going to be helpful in all the areas. But there are few areas which had shown a very good evidences. Um, Other areas still to work on. So as a conclusion, artificial intelligence is really reshaping the healthcare by improving accuracy, efficiency, and patient outcomes with the correct, complete data. That's an important one. And it also like offers a diagnosis, treatment, and monitoring. Monitoring is another important thing with the chronic disease. Definitely, it has a very good result with the monitoring, and so the early identification of the problems can be noted, and the patients can be protected. And ethical use and proper training is very, very important. So AI definitely, it's supposed not just replacing the human manpower, that we need to understand. So it helps for a better patient-centered outcome. For that, we are like nowadays looking into an artificial intelligence in healthcare.
Thank you, Dr. Purneshwari ma'am, for that detailed and excellent presentation. So I would like to introduce the third speaker for this evening. It's Mrs. Geeta Ramesh. She's a registered nurse from Kaiser Permanente with over 20 years of combined experience in clinical as well as academic and expertise in intensive care, cardiac, and postpartum nursing. Ma'am has a strong focus on patient centered and evidence based practice. Ma'am is a proven leader and administrator with extensive experience in mentorship, curriculum development, and academic leadership. Ma'am is the recipient of the Daisy Award for Exceptional Patient Care at Kaiser Permanente and the Certificate of Excellence in Medication Safety, awarded by the Medication Safety Committee at Kaiser Permanente. We welcome you, ma'am. Over to you.
Good evening, everyone. On the occasion of World Health Day, I'm going to present on the topic precision nursing from genetic data to personalized care. Healthcare is moving from generalized care to personalized care, and we nurses play a very important role in this transformation. Today, I will be discussing how genetic data, biomarkers, and real-time patient monitoring will help the nurses to provide personalized care and improve patient outcome. Before we begin, I would like to briefly introduce myself. I have completed my Master of Nursing in Maternity. I am currently working as a registered nurse in Kaiser Permanente at Santiago Medical Center, and I have 11 years of registered nurse experience working in multiple specialty areas, including intensive care unit, cardiac unit, stroke unit, and we got trained in labor and delivery, and presently I'm in postpartum care. In addition to all my clinical experience, I also worked as an assistant lecturer for 2 years and served as a principal in a nursing college for 9 years, and which gave me immense experience in both nursing education and leadership. Overall, combining my clinical experience, teaching experience, and leadership experience, I have over 20 years of experience in nursing practice and education. Through my experience in clinical practice and teaching, I have seen how personalized and patient-centered care significantly improves patient outcome. Let us see the objectives of today's presentation. In this presentation, we will discuss what precision nursing is, the role of genetic data, how biomarkers guide treatment decision, how real-time patient monitoring helps nurses make decisions, personalized nursing intervention, and technology in precision nursing, and finally, the future of precision nursing. First, let us see what is precision nursing. Precision nursing means providing personalized care for each patient instead of giving the same care to every patient. In precision nursing, it uses genetic information like risk genes, biomarkers like lactate, troponin, CKMP, BNP, patient lifestyle like diet, activity, habits, and environment like home, work, exposure, and real-time patient monitoring data like cardiac monitors, vital signs monitors. It helps to guide the nursing decision. The main goal of precision nursing is to provide the right intervention to the right patient at the right time instead of the traditional one-size-fits-all method. Let us see an opening example. A patient SpO2 oxygen saturation trend drops from 96% to 91% while resting. In the traditional care, it was noticed later because the patient was not on continuous monitor. But in precision nursing, it is flagged in real time, because the patient is on continuous monitor and we will be able to notice the drop in SpO2 trend earlier, and we can give the intervention earlier, and there will be less complications, like we can prevent organ damage, those kind of things. Let us see what's the precision medicine versus precision nursing. Precision medicine mainly focus on diagnosis and treatment based on genetics and disease. I can give an example for precision medicine based on my department. In our department, after the baby's birth, after 13 hours of birth of a newborn, before the baby get discharged from the hospital, we have a policy to do a newborn screening on the baby. Newborn screening means it is like there are like hundreds of genetic, metabolic, blood-borne diseases present in this world. We all know about it. What they will do is they will poke the baby's heel, take a blood sample, send to the state lab, and they will do bunch of tests. One of the tests I can give as an example is like Down syndrome. If anything is wrong, the pediatrician will call the parents and they will start the early treatment. That is what precision medicine. It mainly focus on the diagnosis and treatment. They try to find out early. They do the genetics test and they find out the disease condition. They start to treat the baby early. Let us see what is precision nursing. Precision nursing is more patient-centered and focused on prevention, monitoring, and individualized care planning. We nurses play a very major role in implementing precision healthcare because we are the one who was interacting with the patient continuously 24/7. We are the one who are monitoring the data, real-time data at the bedside. So we nurses play a very important role in this. Let us talk why precision nursing is important. Precision nursing is important because it improves patient outcome, reduces complications, helps in early detection of deterioration, reduces hospital stay, improves patient satisfaction, and makes healthcare more cost effective. Instead of reacting after the complication occur, precision nursing will help us to detect the problem early and prevent complication. I can give an example. Couple of weeks ago, I had a patient who is she's a G2 P2. She's a second time mom. She's fresh C-section, 6 hours, less than 6 hours. I got the patient from the day shift nurse. When I went, she said she was lying in the bed. She was still sick, fresh C-section. She was lying in the bed. She told she felt dizzy at rest. She feel dizzy, she feel lightheadedness. I'm like, okay, let me check the blood pressure. That's what we do as nurses first, right? So I checked the blood pressure. The patient's blood pressure systolic was like 90, diastolic was like 60, MAP was like 65. It is not enough me to call a doctor because it's still within the parameter. I just checked her urine output. It was like she still has a catheter because she's a fresh C-section. So her urine output was like 30 ml per hour. And then she has like pitting edema, +2 pitting edema in the right leg, left leg. She also has pedal edema. But it didn't make me much concern because in postpartum, because of the hormones, because of all the fluids she got during labor, and because all the fluids she got during in the OR, there is chance of getting edema. So I'm like, okay, and that didn't bother me. But the patients, something was not okay with me, so I put the patient on the continuous monitoring. I cycled the blood pressure cuff every 15 minutes, and when I went and checked after 15, so boom, the blood pressure drops from 90. The systolic went to 74 and the diastolic went to 49. The map was like around 49 or something. But this time the patient didn't complain of dizziness, but I was not happy. I called the doctor. I just asked the doctor, hey, what do you want me to do? They asked me to give a bolus at the first. We gave the bolus. Again, the blood pressure systolic was low, MAP was decreasing. So I asked the doctor, hey, doc, do you want to order an echo? And they did an echocardiogram, and the patient's ejection fraction came back less than 45%. And she was diagnosed as acute cardiac failure, and they started her on diuretics, started her on beta blockers. And she went home within 48 hours, just like any other C-section mom. By the real-time data, by continuously monitoring her, we were able to find out the condition earlier, treat her earlier. We prevented the complications and less hospital stay, and we are able to discharge her just like any other C-section mom. Next, let us see the role of genetics in healthcare. Genetic data helps nurses, healthcare providers to identify the disease risk, predict drug response, prevent complication, and personalize treatment plans. When we understand a person's genetic makeup, we gain insight into their risk for certain diseases long before the symptom appear. For example, the variation in specific gene can indicate increased risk for cancer, heart condition, or metabolic disease. For example, when they do the cardiac genetic testing, they will be able to identify if there is any gene mutation responsible for inherited heart conditions like cardiomyopathies. For diabetes, most white people with type 1 diabetes have genes called HLA-DR3 or HLA-DR4, which are linked to autoimmune disease. If a person shared the gene, the person is at risk of getting diabetes mellitus. Regarding cancer, the BRCA gene testing guides the screening, and we will be able to assess the risk for breast, ovarian, pancreatic, or prostate cancer, and we'll be able to give lifestyle counseling, and there is chance of prevention. Next, about the medication reactions. In pharmacogenomics, we look at how a patient's gene affect their response to medication. This helps us to choose the right drug and right dose and fewer side effects. From a nursing perspective, genetics supports more personalized teaching, monitoring, and planning. It helps us to anticipate complication, adjust intervention, and guide patients towards preventive steps based on their individual risk. Let us see the biomarkers. Biomarkers are biological indicators that show the health condition or disease condition of a patient. Examples of biomarkers include blood pressure, blood glucose, hemoglobin, infection markers like lactate, procalcitonin, oxygen saturation, cardiac markers like troponin, CKMB. We already use biomarkers every day in nursing practice, but in precision nursing, we are using these biomarkers to personalize the treatment and nursing decision. Let us say real-time patient monitoring. Real-time patient data includes vital signs monitor, telemetry monitor like cardiac monitors, wearable devices like Fitbit, Apple Watch, When I talk about wearable devices, I can say one of my patient, actually he was a liver transplant doctor. He was seeing, like any other day, he was seeing his patients in the clinic, and his Apple Watch alerted him he was going into rapid AFib and RVR. When he looked at the Apple Watch in the app, he says that his heart rate is like 164, and he came to ED, and from ED he was brought to our unit, and we started him on DILT drip. And even in the DILT drip, when we are titrating up and down, his alarm, his Apple Watch give alarm earlier than the cardiac monitor which is attached to him. He used to press the nurse button and say, hey, you know what, I look like my heart rate is going to 160. And we have to run into the patient's room, and we have to bump up with a DILT drip every time. Because the wearable devices like Apple Watch is very accurate in, it's good in identifying the rapid AFib at times, but they don't identify heart attack. But to identify the rapid AFib, it really helps for the patients. Next is like Zeo Patch. Zeo Patch for that is also one of the wearable devices, Zeo Patch for cardiac. So like a couple of years ago, my heart rate was like in 110s, 120s. And when I went to my primary care provider, she asked me to wear the Zeo Patch, and we have to wear it for 14 to 21 days. And it will be, you can do all the activities. You can do all the activities. You can go to gym, you can take a shower. Nothing is going to affect the monitor. After 14 days or 21 days, if you send it to the hospital, they will interrogate, and if anything is wrong, your doctor will call you guys. But that helped for me. Luckily, I didn't have any issue, but that's one of the wearable devices, advanced wearable devices we have to monitor the cardiac irregularities. Next is the continuous glucose monitor and electronic health records. Dr. Buona was talking about the electronic health records just before. We use Epic in our hospital. So, for example, I am in California. One of the fine, interesting thing in electronic health records here in US is most of the hospitals are using this Epic software. But even though if they don't use Epic software, I'm from California, if I relocate to Florida or Georgia, in that hospital, if they have that software, I can, I have to give permission to that health provider to use my records from California. And, in real time, they can look everything. They don't want to do the blood work when I go from one hospital to another hospital. They just look at the health record, and they can start the treatment immediately without any delay. That's one of the fine thing with electronic health records. Next is remote patient monitoring. For remote patient monitoring, AACD, I can say, if the patient has an AACD implanted, if the patient is going for any VTAC, or if the patient, if the monitor is firing incorrectly, that information will be given to the rep. We have the ACD here, they mostly uses Medtronic, Biotronic peoples. So these devices will send the information to the provider, and the provider will sometimes they can even interrogate the AACD device remotely. Otherwise, if they are not able to interrogate the device, if there is any fracture in the leads or anything, they will ask you to come to the hospital, and they can do it. Like that's sort of remote patient monitoring. Next is like smart hospital equipment. We use smart IV pumps. Smart IV pumps, like in my hospital, we use Alaris, so many things. But the main fine, interesting part is you don't want to enter anything in the IV pumps, the smart pumps. You have to scan the patient, scan the MAR, scan the pump. That's all you have to do. whatever the doctor has ordered, including the dosage and medication, will be interrogated in the IV pump. You just have to press the start button. You have to see whether it is correct or not, because it's a machine. We don't want to make an error when you're giving some drips. So you have to confirm it and press the start button. So main thing with the smart IV pump is to prevent medication error. Okay, it interrogate with the electronic health record and with the IV pump, and it prevents so much medication error. So as I said, the real-time data allows for continuous monitoring of patients instead of checking vitals every few hours. Like in traditionally, those days when we were doing our nursing, I think it's every shift or every 4 hours we check the patient's vital signs. But now, because of the continuous monitoring, since the patient is continuously connected to the monitor, it allows the nurses to shift from the reactive to proactive care. Before something happens, the nurses can catch it in real time and can prevent the complications. So that's what nurses use real-time data to detect early deterioration, prevent complications. We can even monitor infections, monitor oxygen levels, monitor cardiac patients, improve patient safety, adjust care immediately, and improve patient outcomes. So real-time data helps nurses to make faster and better decision. When we talk about another example I can say is if the patient's heart rate is rising or O2 sat is decreasing, it's a red flag for sepsis alert, early sepsis alert. And if the patient has a continuous glucose monitor, and if you see a spike in the CGM, immediately you can either do a diabetic teaching for the patient, or you can talk to a provider and do an sliding scale insulin adjustment. And suppose if the patient is on a telemetry monitor, if you are seeing any abnormal rhythm or something, check the patient's medication, review the medication. If the patient took if the previous nurse gave the medication for the patient, or if it is held, like sometimes because of the heart rate, we held the metoprolol, but that's really needed for sometimes for arrhythmias. Just check whether the patient got it, and if you see a lot of PVCs, check the patient's potassium magnesium level, and we can replace it if it is low. It helps to prevent further rhythm issues. Tailoring nursing intervention based on biomarkers and live data. So biomarkers, we know that's the troponin. Here, the biomarkers is high troponin. In cardiac care, biomarkers and live EKG data guide nearly early intervention. High troponin plus ST changes will signal the need for immediate ischemia management. In case if the patient has high troponin and if there is ST elevation, immediately you can call rapid response, put the patient on oxygen as per doctor's order, heparin drip. If it's a STEMI, immediately take the patient to the cath lab. So it will help to preserve the organ, preserve the cardiac muscles. Next is the telemetry. If the patient is on continuous telemetry, it gives an continuous insight into rhythm changes. Somebody will be monitoring we nurses when we are in the nurses station, we have a cardiac telemetry monitor, and we continuously monitor the patient's rhythm. When we detect any changes, for example, if there is a lot of frequent PVCs, or if there is any new onset AFib or prolonged QT intervals, it often signals a reversible issues. It can be reversed. So we nurses play a key role in reviewing the medication. As just now I talked about it. We review the medication that may affect the rhythm, checking for interaction, and drawing electrolytes, like as I said, potassium, magnesium. Check whether most of the time morning when the patient is on cardiac urine, we check the mag and potassium and we replace it. Sometimes if the patient is on diuretic, the potassium follows the P. So if the patient is on diuretic, maybe when you come to the night shift, the potassium is low again. check, and if the patient got the potassium in the morning, also a diuretic, definitely check if there is frequent PVCs. You can ask the doctor, hey doc, do you want to order a potassium level on this patient? I can see a lot of PVCs. So you can draw the labs, and if anything is wrong, immediately you can replace the potassium magnesium. That will prevent more serious arrhythmias like VTAC or VFib. When the patient is having a VTAC, VFib, unnecessary chest compression, wrist fracture, or sometimes transfer to ICU, we can prevent those complications. That is, to reduce the need for advanced intervention can be prevented if the V nurses play an important key role. Next is about sepsis and infection. For sepsis, the combination of biomarkers like lactate and procalcitonin with real-time vital trends is extremely powerful. A slight rise in respiratory rate or heart rate or increase in temperature, decrease in blood pressure may be the earliest clue. We all know about it, right? This allows us to start the sepsis bundle. If you feel like if the patient's 2 times, if the temperature is increasing, it's above like 100.1 degree Fahrenheit twice, and if the patient heart rate is in like 120s, O2 sat is decreasing, of course you can call the provider and ask for to initiate the sepsis bundle, like ask for, hey doc, do you want to order a lactate level on this patient? Do you want to bolus the patient? Those kind of things you can escalate, and which will help to improve the survival of the patient, decrease in hospital stay. For example, I can say, I can talk about my unit. Once, like maybe a month ago, I got a patient from labor and delivery. She was a vag delivery, like less than 2 hours. She came to our unit. She was ruptured. Her membranes were ruptured greater like 16 hours. The membranes were ruptured for 16 hours. She was a G1, P1 mom. Her temperature was great in LND. When she came to me, I checked the blood temperature in the beginning. It was like 100.3. I'm like, it's not it. 100.4 is the map of the cutoff for the sepsis protocol. So I'm like, okay, let me wait. I checked the temperature again in another 15 minutes. It was like 100.4. I checked, we 15 more, and the temperature was high. I got 2 readings greater than 100.4, and her O2 sat was decreasing. Normally, we like to keep the O2 sat for OBG patients for 95%, but it was like 92, which is a red flag for me again. Her heart rate was in 120, again a red flag. She felt warm. She feels flush, so I have to call the doctor. Hey doc, do you want to draw a lactate on this? We did, and the lactate came back as 4, and immediately we have to bolus the patient. We bolus the patient, also draw the blood culture, and we also started her triple antibiotic. They diagnosed her with chorioamnitis, and after that, she was fine, and she was DC'd within 48 hours with no fever for 24 hours. Like any other patient, she was able to go home in 24 to 48 hours, less hospital stay, and prevent complications. Next is diabetes care. When I talk about diabetes care, if a person is using a continuous glucose monitor, it gives a minute-to-minute glucose trend. If you see spikes after meals, we adjust the meal timing. If there are hypoglycemic episodes at night, we modify the medication schedule. This is called dynamic personalized care. In diabetes, biomarkers like A1C combined with real-time glucose data will help us to tailor the patient teaching and medication timing. Variability in glucose can tell us a lot about diet, stress, or incorrect insulin administration, and this makes our intervention more specific and more effective. I can give a quick example about the CGM. I had a patient who she's a DM patient who has a CGM and who has an implantable insulin pump. So when her blood glucose drop, her mobile give an alert. She knows, she goes to hypoglycemia me at midnight. So like I had her for 2 days. So every time like around 11:30, she will bust the collet and she say, "Hey, can I get you graham crackers?" Because the graham crackers will bump her sugar up. She know her how to manage her insulin thing. If you feel like there is frequent spikes, you can have to give diabetic teaching for this patient. You can give some nutrition. Diabetics educator has to personally see this patient. We have to the individualized, personalized care for this patient. Next, let us see the statistics of precision nursing. So studies have shown that early detection of patient deterioration using continuous monitoring can reduce ICU admission, reduce hospital mortality, and reduce complication. Precision nursing helps to identify the high-risk patient early by using biomarkers and real-time monitoring and allows early intervention to improve patient outcome. I can give an example for this. So I was working in cardiac unit. It was beginning of my shift. I was just looking at my my patients. I just added my patients to my list and I was looking at my telemonitor. I'm like, the QTs is prolonged, like it was like greater than 500 millisecond. I was like, it's not okay for me. So I was looking at one of the reason for the prolongation of QTC is Zofran, getting a Zofran medication. Zofran can cause the QTC to prolonged. So I was looking at the patient's more and I can find that the patient got a Zofran like 5 p.m. that evening. I'm like, okay, then I call the cardiologist. I'm like, hey, doc, do you know this patient QT is prolonged? Do you want to DC it? Because nobody should give the medication for the patient for nausea because we don't want the prolonged, you all know, prolonged QTC can lead to torsades de pointes, and it also can lead to VFib, sudden cardiac death. We don't want that to happen. No complication, no ICU admissions. We have to discharge the patient as quick as possible. Instead of Sofran, we can go for some other medications like Reglan. So I called the doctor. I made them to DC the Zofran. I called the pharmacy, DC it. So we were able to buy those precision nursing decision. We were able to decrease the ICU admission. So that's about the statistics. Next, let me talk about precision nursing flow. This diagram shows how precision nursing works. First, we collect genetic information, then we monitor biomarkers such as blood pressure, glucose, hemoglobin, infection markers like lactate, procalcitonin. We also monitor real-time patient data like vital signs. Based on this information, nurses assess the patient and provide personalized nursing intervention, which can lead to better patient outcome. Next, let us see a case study. It's related to my unit. Like 2 weeks ago, I had a patient. She's a G1P1 mom, very pleasant family. When I came to my shift, I went into the patient room. They're very pleasant couple, very beautiful baby girl. It's a normal, spontaneous, normal advanced delivery. When I went there, it's a beautiful family. It was like 8:15. So there was family. Our visiting time ends at 8:30 p.m. So I was like, I went and picked in and I told, hey, you're having some good time with the family. Let me come back later. So I stepped out of the room at 8:30. I went in. I checked at the mom's fundus. Fundus looks firm, beautifully firm. I look at the bleeding. It's very light bleeding, rubra. I talked about few things about, postpartum care and stepped out of the room. And now dad came, like within less than like 2 or 3 minutes, dad ran to the nurse's station and say, hey, my wife passed a big clot. I'm like, what? I just looked at her. Her fundus look really firm. So I went there. Yes, there is a 4 big clots. So I'm like, I took the mom. Mom was little dizzy. She was little fatigued. She was little looking pale. So I took her to the bed. I checked her blood pressure. First thing I checked her blood pressure. Blood pressure was like 90/60. Again, that is normal. That's within limit for in our unit. So I'm like, okay, but the heart rate is little. It's 110 beats per minute. But I just look at the fundus. It's still firm. bleeding is light when I pressed. There's nothing wrong. So I went, I brought the weighing scale, weighed the pad, and it was like 430 milliliters. So I have to call the OBGYN. I will just call the OBGYN, hey doc, the patient has past clot. And sometimes the patient has past clot, and if the fundus is really firm, they don't do anything except they do a stat CBC and they check the bleeding. So she said, okay, I will put a stat CBC draw, and she did and their lab was here where she put a stat CBC and their lab was there. But I put the patient on continuous blood pressure monitor. So within 2 minutes, I was not comfortable. I feel something is wrong. My mind is like, my inside was like, no, 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 you have to go and check the bleeding again. I went there. When I look at the fundus again, when I press the fundus, I can see a little bit of gush, little bit of gush. There is no trickling after that. So I called the doctor, hey doc, I found little bit of gush. There is no more trickling. But doctor, do you want to bring a ultrasound and check her fundus? Sometimes there will be placental bits which is causing, we may not be knowing. And I felt that uterus is, the length of the uterus fundus is increasing in length. The first time when I checked, it was one below U, and after that it was like one plus U. And she was like, sure, our OBGYNs, we are the advocate for our patients, so they respect our decision, our suggestion. So she came with ultrasound. Yes, yes, the patient had a placental bed. They have to take the patient, and her blood pressure was also started to drop. She was really pale, really, really pale, and they have to take her to the OR, do a DNC, and they have to put a Bacri because the lower uterine segment was not contracting. The the fundus was firm, but the lower uterus segment was still relaxed, and she was forming clots there, and they had to put a Bacri on her. So in the precision nursing approach, we were able to find out with the real-time monitoring and the hemoglobin biomarker tracking, we were able to find out that she is losing blood too. And we have to, for my patient, they have to give IV fluids, they have to give pitocin times 2, methadone, TXA, and also she was on a Bacri. Bacri is a thing we help to, it's a balloon which helps to contract the uterus and prevent other next bleedings. We were able to, we put her on frequent reassessment. We gave 1 unit of blood. We gave her personalized education, and if something happens in home, like passing any clot, greater than size of an egg or greater than size of an golf ball, definitely call the OBGYN. And we were able to stabilize this mom within 6 hours, this beautiful mom within 6 hours, and we avoided an ICU admission, and we were able to discharge her in 48 hours. Just like any other VAG delivery moms. Normally, VAG delivery, we discharge in 24 to 48 hours. So we were able to discharge her beautifully. Next, let me talk about personalized nursing intervention. Based on patient data, nurses can provide personalized pain management. When I talk about pain management, in my unit, we have to, when the moms are breastfeeding, they used to get the uterine cramps. Instead of giving a narcotic pain medication or instead of giving a Tylenol for the patient, it is better to give ibuprofen for the patient, and because ibuprofen works wonder for cramping pain rather than Tylenol. So that's a personalized pain management. Or if the patient needs some warm pack, I can give that. The nurses has to give that as a personalized pain management. Next is like nutrition plans. Again, if the baby is in my unit, we get small for gestation age babies who weighs less than 2,000 gram. In those cases, I can let the neonatologist or the pediatrician, hey doc, instead of most of the time when the baby is small for gestation, we go for a triple planning. Triple planning for breastfeeding, pumping, and then formula. So we ask the doctors, hey, a pediatrician, hey, do you want to start this baby on 22 cal instead of 20 cal? Normally for a term babies, if the parents want to formula feed, we give 20 cal. For this specific babies, they need extra nutrition. That's personalized nutrition plans. Okay, next is mobility plans. when I talk about mobility plans, after epidural, the patients won't be able to walk to the bathroom. For us, catheter is not an indication if the patient got an epidural. We have to take the patient to the bathroom to make her to void within 6 hours of delivery. So once I had a patient like maybe 6 months ago. I got her like 6 hours after birth. Whenever she wants to use the bathroom, she say, "My legs are heavy. I'm not feeling it really good." I'm like, it's 6 hours. Normally, epidural wear off by 6 hours. Okay, for some patients, some exceptional cases are there, right? So I checked her pulse. It was wonderful, but legs felt a little bit cold. But I can feel the pedal pulse. I'm like, okay. Um, uh, I took her in Sarah study. It's not a walker. We have a specific, equipment to take the patient to the bathroom. It's like a little ride kind of thing. We call it a Sarah study. I took her in the Sarah study. She was able to pee. Took her back in the bed, but I turned the bed alarm on. I told her, "Don't get up by yourself. Call me until we call something called egress. We make sure the patient was able to walk. We say you didn't pass the egress, so I have to check one more time until your legs are feel okay. You should not feel funny with the legs." And she said yes. And after 4 hours again, she called me. "My legs are still heavy. This is not okay." So I called the anesthesiologist. Here I have to call the anesthesiologist, and I told, "Hey doc, do you know this patient has still she feels heavy on her leg and legs feel a little bit of cold, numb, looks like a food drop. Do you want to come and see?" Yes, the anesthesiologist came. He diagnosed with food drop for this patient, and because when during delivery they put the legs on the stirrups, right? So she got nerve compression, and the crazy part is the anesthesiologist told that it will take 2 to 3 months for her to walk without a walker. So after a VAG delivery, because of the nerve compression, we did a PTOT consult, and she has to go home with a walker. Like mobility plans, plan accordingly step by step. Next is regarding the mental health support. When the patients, so after delivery, we admit the patients in the postpartum unit. When the patient comes to a postpartum unit, we give a paper, we give a form to the patients called Edinburgh Postpartum Depression Scale. It gives an idea to the OBGYN how the patient mental status was in the past couple of weeks. We ask the patient to fill at the time of admission to the postpartum unit. If the score is greater than 13, we will put a social work consult. Normally, we all know that because of the postpartum hormones, postpartum moms are more prone to get postpartum depression around like 3 or 4 weeks. For the first few weeks, they will be having postpartum blues. That is perfectly normal because all the hormones rushing in, they will cry, everything. But if it happens after 3 to 4 weeks, definitely they have to need it's diagnosed as postpartum depression. They need treatment for that. So yeah, that's about the mental health. Next is the medication adjustment. We talked about the insulin. In case if the patient has insulin is spiking up, we have to check the timing, meal timing. If you want to adjust the dosage of the sliding scale, we can talk to the doctor, and you can ask about adjusting the dosage. Next is infection prevention and providing data-driven patient education. Based on the patient's history, you have to give education to the patient. Like if it is a C-section postpartum mom, give education based on C-section postpartum mom. If the mom is having hypertension, give the education based on her data present in the EPIC, in her medical record. Based on that, give the education. Next is about the discharge plan and discharge planning. So when you give some education or you need to do the discharge planning based on the patient's picture, the patients will take it more. They will accept it more, and they will follow it. So nursing becomes more individualized instead of routinely talking about discharge of a patient. Give discharge education based on the patient's EMR, like based on the medical record of the patient. Next, let us see technology in precision nursing. Technology plays a major role in precision nursing. Examples include electronic health records, artificial intelligence. Bonamam talked wonderfully about artificial intelligence, wearable devices, we just spoke about it, remote monitoring, smart infusion pumps, clinical decision support system. Again, Bonamam talked about that, and telehealth. Technology helps nurses to make faster, data-driven decision and improve patient care. About, I can talk few things about I just talked about AACD. As I said, AACD can be monitored remotely, and this AACD machine will allow the device to send information to the doctor's office wirelessly. If the rep find anything funny, if the AACD is firing incorrectly, they will ask you to come to the ED, and they will, interrogate your pacemaker AACD, and they'll send you home. Next, challenges, key implementation challenge. Some challenges include lack of training, data privacy concerns, because again, when it comes to EMR, data privacy concern, technology cost, it's a large group of people. Technology costs a lot. Data overload, again, large group of people. Data overload, ethical issues, and implementation. Anything comes into the internet, ethical issues happens, and implementation challenges. So education, training, and policy support are needed to implement precision nursing successfully. Let us see the future of precision nursing. In the future, nurses will use genetic reports, AI decision tools, remote patient monitoring, predictive analytics, smart hospitals, and virtual nursing care. Instead of treating patients or after complication occurs, we will predict complication before they happen and prevent them. The future of nursing will be personalized, predictive, and preventive. We come to an end of our presentation. So precision nursing is not just about data. It is about understanding of the unique story of every patient. By combining genetic insights with real-time information, nurses can intervene early, care smarter, and make a meaningful differences in patient lives. Thank you for listening. I hope this presentation gave you an understanding of precision nursing and its importance in modern healthcare. And happy to answer any questions. You can type it in the chat box, and you all have a wonderful good night.
Thank you, ma'am, for that thought-provoking session. Thank you, dear speakers, for your time and efforts to raise this webinar and to address everyone here. Thank you.